and I'd like to thank you for the opportunity that the LEGEND initiative is going to take to talk about both research that we've completed and ongoing work and opportunities to get involved in generating reliable evidence for actionable healthcare decisions. But without any further ado, I'd like to turn the floor over to Anna Ostropolets, a physician and PhD student at Columbia, to kick us off. Anna, please.
Thanks a lot, Mark. You can go right to the first slide. You may think, if you're not familiar with LEGEND, you may think of LEGEND as of yet another study on diabetes treatment or depression treatment or hypertension treatment. But in fact, there are key things that distinguish LEGEND from what you usually see in observational research. And when you think about the studies that are out there, researchers would usually pick one question, which means that they would investigate one target and one comparator treatment at a time. They would use whatever research methods they think are appropriate, which oftentimes results in them not really accounting for all of the potential source of bias. And then when you look at the published results, you would see that researchers mostly publish significant findings, which means that they oftentimes discard something that they feel is not interesting or some insignificant findings. And what LEGEND proposes and uses instead is a set of principles which allow for transparent, reproducible, and robust research. So what we do is we use the pre-specified design, which we publish in the form of protocol, and then we disseminate whatever results we obtain from the study to make sure that we avoid this publication bias. We use systematic process across all research questions to make sure that we really get these calibrated true estimates. We do it at a large scale, which means that we're examining thousands of treatments and run the analysis on multiple data sources. And of course, we use the best practices, which is large-scale propensity score modeling, really extensive diagnostics, use of negative and positive controls, and much more. And that already sounds good enough, but what you can see here is the way you can apply those principles in your own research. So what you would do when you start with the research question, instead of looking at one pair at a time, you can look at a drug class and you can examine multiple treatments and compare them. And you really want to spend a lot of time on designing your study. So you would like to make sure that you account for all of the potential sources of bias on the design stage. You probably want to come up with a multiple sensitivity analysis, like with the easy example being as treated and intent to treat. Then you would like, also on this stage, you can actually leverage the OHDSI tools such as cohort diagnostics to make sure that you'll be pursuing the question and using the cohorts that are really comparable, and that you really account for all of these small details that make or break your study. You probably want to run it on a multiple databases, and here you can say that, okay, but what if I only have one data source at my disposal? And our answer will be that OHDSI provides you and any collaborator with this great opportunity to run a network study, so you can really leverage different data sources with a different provenance, with a lot of patients to make your analysis robust. And after that, when you run this analysis, you, similar to what we do in LEGEND, really want to spend a lot of time on diagnostics. You want to examine your propensity score. You want to check the covariate balance. You want to make sure that you account for the systematic error by examining your calibration plots. And after all, you would like to publish all of your results. And the process outlined here would actually make your paper highly desirable paper to any journal. And Ray will follow up on that with a perfect example of the study published in a high impact journal, which resulted from the LEGEND study.
Thanks, Anna. So I have the privilege of sharing with you some of the existing work. For those of you who have been with the community for some time, you may recall a lot of these figures and analyses presented from the 2018 symposium. This was, I think, quite a banner year for LEGEND. So the motivation behind very quickly behind the LEGEND hypertension study was that there were new guidelines released for hypertension in about 2017 and 2018. So in 2017, the ACC/AHA came out with new guidelines, and in 2018, the European Society for Cardiology followed. However, across both these guidelines, there were multiple recommended first-line drug classes, a total of 5 drug classes spanning about 29 individual drugs. And as you can see on the figure in the right, the literature behind that really powered these guidelines and motivated these were still quite sparse in terms of direct head-to-head comparisons, with a lot of these being based on older RCTs that were done many decades ago. And the question was, could we help fill this gap in terms of the literature and the evidence and do a better job comparing a lot of these drugs more directly? So the primary manuscript was an effort led by Mark Suchard, which was ultimately published in 2019 in the Lancet, which was a class-level comparison across the 5 drug classes with 55 outcomes across 9 databases, which included the 3 primary outcomes of acute myocardial infarction, heart failure, and stroke. Also in this main manuscript, there were a total of almost 5 million patients, and LEGEND hypertension involved the running of over 20,000 calibrated and propensity score adjusted hazard ratios, as Anna had alluded to. Some of the key findings from the study were that thiazides were better than ACE inhibitors for primary effectiveness, and that non-dihydropyridine calcium channel blockers were inferior. And I think those were some of the key ones that came from it, and I think it was a hugely impactful study. As a follow-up, there was also a question of within thiazides, chlorthalidone had been around for a long time and were often the medication that was used within trials and supposedly it actually does have a longer half-life. However, in practice, hydrochlorothiazide, HCTZ, is much more commonly prescribed. So there was a question of whether chlorthalidone should still be recommended as the preferred thiazide, especially with our finding in the first main manuscript of thiazides being potentially better than ACEs. George Ripsack led this study, and which was needed because there were no direct head-to-head comparisons, even though the VA did have a clinical trial in progress around this topic. And this paper ultimately came out in 2020 in JAMA Internal Medicine of this comparison. This was in 3 databases because we were limited to those with greater than 2,500 exposures, capturing about a little over 700,000 patients, and found no real difference in effectiveness. That's the figure that you can see right here, closer to the bottom on the bottom left, and on the bottom right and on the right side, you'll see really the secondary endpoints and safety outcomes, which really reflect that hydrochlorothiazide actually had fewer renal and electrolyte abnormalities, which really reassures, I think, the scientific community and those on HCTZ that this was a safe choice. This was followed by Chan's paper in hypertension on beta blockers, essentially that the ACC guidelines no longer recommended beta blockers, however, the European guidelines still did. Beta blockers we know are a fairly heterogeneous class, with the 3rd generations having more vasodilatory effects, so that would be like your carvedilol. There were a few direct comparisons against atenolol, and so we wanted to dig further into this class as well. This was again on 3 databases that had greater than 2,500 exposures, capturing almost 400,000 patients. And there was no significant difference between these 3rd generation beta blockers and atenolol. However, there was a higher risk for stroke when we looked at these 3rd generation beta blockers against ACEs or thiazides, suggesting that once again that perhaps beta blockers should not be as first line as some of these other ones. And this leads me quickly to the study I had the good fortune of leading, which was the ACE inhibitors versus ARBS study. Once again, you'll see a recurring theme of these are equally recommended first-line therapies, act along the same physiologic pathway. But we know that ACE inhibitors are much more commonly used, even though we know they also have some side effects, like people may have heard of cough or angioedema being associated with ACEs. And we don't have enough in the literature head-to-head to compare. This ultimately was run on 8 databases because these are slightly more commonly used drugs. You ended up with about 2.3 million on ACEs and almost 700,000 on ARBs. And there was no significant difference in the primary outcomes, which included acute MI, heart failure, stroke, and a composite endpoint of those events. And this was published recently in Hypertension. Across 51 secondary and safety outcomes, there was a difference in pancreatitis, angioedema, cough, and GI bleed. The cough and angioedema were actually reassuring to see, and especially with particularly strong effects, because that's well-known side effects of the ACE inhibitors, as I mentioned before. And those two do remain significant, even with a fairly conservative Bonferroni correction. And with that, I would like to hand it over to Yuan Lu, who is an assistant professor at Yale and an outstanding researcher and collaborator with the LEGEND group.
Thank you, Ray. My name is Yuan. Today, I'm going to share with you result of a new collaboration as an extension of the LEGEND Hypertension Initiative. A little bit background, all of the study that Ray just showed you have focused on monotherapy of hypertension as a first-line treatment. However, in practice, studies show 70% of patients with hypertension cannot achieve their blood pressure control target with monotherapy alone. So there's an important clinical question is that what is the optimal therapy for treatment escalation among patients with monotherapy who cannot achieve blood pressure control goal? So as an extension of the LEGEND Hypertension Initiative, we aim to conduct a large-scale observational study within the OHDSI community to characterize real-world utilization of dual combination therapies for hypertension among patients with hypertension. Next slide, please. So we look at all 5 major drug classes of antihypertensive medication. These include ACE or ARBs, calcium channel blocker, thiazide or thiazide diuretics, and beta blockers. We look at all the dual combination of this drug class. These generate 12 exposure cohorts. Next slide. Here we use 11 EHR data sources, mainly from the Asian Pacific countries. Many of these data partners are first time joining the OHDSI community. So we mobilize them using the LEGEND hypertension principle that Anna just described, and I will also talk about some lessons learned from this new collaboration. Altogether, these 11 data sources cover 118 million patients across 8 countries and districts. Next slide. Now here is a table showing you the distribution of dual combination therapies across these 11 data sources. By just looking at this color, you can see there's variation in treatment utilization for hypertension escalation. For example, among the Australian database, cohort number 2 and number 3, which means starting ACE and ARB first, following by a calcium channel blocker or diuretics, are common in Australian database. But however, when you look at the Korean database, it seems cohort number 7 and number 8, starting CCB first, and then following by an ACE and ARBs or beta blockers are more common in this country. Next slide. We also found heterogeneities in treatment utilization by age and sex. Here I use IQVIA Australian database as an example. The first figure on the right-hand side shows different age distribution. The yellow color shows age 45 to 64 years old, whereas the blue color shows age 65 and older. So you can see that younger patients are more likely to be prescribed ACE and ARBs than a CCB or diuretic compared to older patients. And at the bottom, this graph shows the gender difference. we see that women are more likely to be prescribed with diuretic first, and then following by an ACE and ARBS or calcium channel blocker compared to men. Next slide. And then here we're looking at the treatment pathway. Again, just selecting two databases as an example, looking at the IQVIA US database and IQVIA Italian database, we see that large variation in treatment pathway across country. It seems in the US database, there's much more layers and more complexity in using the drug, whereas in Italian, the layer are fewer, and you can see that more homogeneous treatment utilization pattern within the Italian database. Okay, next slide. Finally, just to summarize the key findings and lessons learned from this new collaboration, we found that large variation in transition between monotherapy and dual combination therapy for hypertension across different countries and by demographic subgroups such as age and sex. These will lay the foundation for the future research, which is to identify what is the best combination for which patient. Finally, a lesson learned from this study is that we found that using LEGEND hypertension principle is very helpful to mobilize collaboration with OHDSI data partners, because all of us follow the same principles. However, we've also found that substantial effort was required to ensure data quality and alignment of method across these data sources. Even though all of these data partners mapped their EHR to OMAP common data model, the data quality vary, especially some of these data partners are first time entering the OHDSI community. So researchers need to pay attention to this issue when establish new collaboration and carefully examine the data quality. With that, I would like to turn over to my colleague, Dr. Rohan Kira, who is a promising cardiologist at Yale University, to talk about the LEGEND Diabetes Initiative.
Thank you, Yuan. And I'm glad to switch gears here. The success of LEGEND Hypertension ensured that we had to take in a new direction. And LEGEND Diabetes, Type 2DM, which is T2DM, is a mouthful, but it's actually an important advance for our community to go in a new direction. Please advance this slide. And I think the key reason that I'm going to focus on is what is the motivation of doing LEGEND Type 2 diabetes or LEGEND diabetes is the fact that we recognize that diabetes is a major problem in terms of causing both premature morbidity and premature mortality. Patients suffer from a combination of macrovascular disease, which is coronary artery disease, or which include and other atherosclerotic cardiovascular disease like strokes, heart attacks, as well as microvascular disease like nerve problems, neuropathy, or retinopathy. And please advance. And while we recognize that improving the glucose control or achieving better glycemic control reduces the risk of microvascular disease, next please, it has no known effect on the macrovascular disease. So even though we have focused diabetes management exclusively on blood glucose control, we actually do not impact either macrovascular disease or coronary artery disease or patients' risk of dying with this approach. Please, next slide. And this is the entirety of our current approach. So if we focus on our current guideline recommendations, they focus on identifying patients with type 2 diabetes, based on an elevated blood sugar, and then going after the blood sugar as the target to treat. So our first-line therapy is often metformin. Metformin is a long-use, safe drug in type 2 diabetes management with some modest benefit even on the macrovascular side. But then most patients are unable to be managed on metformin alone and still have elevated blood sugars. This leads to a second-line array of second-line drug therapies, each with a different mechanism of action, as well as a different approach towards lowering blood glucose. There are many drugs in these classes, and within these classes, there are individual drugs. We focus on 4, which are the most widely used drug classes. Next, please. And I think the key aspect I want to highlight that all these drugs have an effect on blood glucose control and are used effectively for that indication. There is a substantial variability in how they affect cardiovascular risk. So the most commonly used second-line drug, sulfonylurea, which increase the secretion of insulin from the pancreas, they have never been evaluated in large-scale cardiovascular outcomes, RCTs, because that was never the strategy of evaluating these drugs. Newer classes of drugs that focus on different mechanisms, including DPP-4 inhibitors, were actually tested in cardiovascular outcome studies that were based on a recommendation from the FDA to assess this in these sort of large trials. And the newer drugs that have been tested in this class have a neutral effect. However, two promising drug classes have emerged, including SGLT2 inhibitors, which in large cardiovascular outcome trials have shown to reduce the risk of MI, death, and heart failure for most drugs in these classes. Similarly, GLP-1 receptor agonists, which are injectable drugs, also have reduced the risk of cardiovascular risk. Next slide, please. However, even though we recognize that these drugs are all available in clinical practice, there is currently no evidence to choose one over the other based on head-to-head direct evidence. People have tried to do indirect meta-analyses, which compare with a common control versus the relative difference between these agents and their control arms, but that's highly limiting. Therefore, our focus is on improving the understanding of which drugs may be superior in lowering cardiovascular risk with these in diabetes. And there is a critical need to use real-world evidence or real-world data to generate evidence to guide this decision. With this hope in mind, we actually identified two key aims for LEGEND diabetes. Next slide, please. The first is to evaluate the relative cardiovascular effectiveness and safety of all second-line antihyperglycemic drug classes, which I mentioned in the previous slide. And then, because there are multiple drugs in these classes with varying amounts of evidence for their cardiovascular effectiveness and safety, we wanted to focus on individual drugs of the second-line antihyperglycemic drug classes to study in LEGEND type 2 diabetes. And with that, I'll hand it over to Aki.
Thank you, Rohan. So as it should be clear to the audience by now, LEGEND is a real-world data analytics at really an unprecedented scale. And as such, it often reveals some of the shortcomings of the existing statistical techniques. And in the LEGEND spirit of generating reliable evidence, it's important for Odyssey to address these shortcomings as we discover them. So I'll discuss the challenges and opportunities around the causal inference techniques for survival outcomes, and Fan will describe her ideas on how to carry out evidence synthesis on a federated data network model. Next slide, please. So here are some results from a positive control experiment using plasmode synthetic data. This experiment investigating bias and root mean squared errors in the treatment effect estimates. And different estimators vary in their method for estimating propensity score, but they all use propensity score matched Cox regression model to estimate the treatment effect. And matched Cox regression is the current gold standard for survival analysis, and it's also what the Odyssey uses. And what this plot clearly shows you is that the matched Cox regression is biased. Now, you could argue that this is not the worst type of bias because it's a bias towards a null, inflating false negative, but it's still a bias nonetheless. Next slide, please. So this bias in Cox model is actually a well-known issue, and there has been in the causal inference literature, there has been alternative proposals that has better theoretical properties. But the best method in theory is not always the best method in practice. Next slide, please. Yeah, and some causal inference experts have argued that the matched Cox regression actually works better than other method, despite in a practical setting, despite its shortcomings. So what I'm working on with my colleague Betsy Ogburn and our student Xiao Xu is to implement a range of state-of-the-art causal survival inference techniques and systematically evaluate their performance in the real-world LEGEND setting. And with that, I'll hand it over to Fan Bu, who is a hotshot postdoc in the Mark Suchard group at UCLA.
Thank you, Aki. So next, I will discuss emerging methods on evidence synthesis across federated data sources. So in the OHDSI network, the typical way of doing studies is to execute analyses at separate data sites and then combine the findings. Now, the method we're using is the traditional method where we get a point estimate for the effect we care about and then use meta-analysis methods to combine those point estimates to get an overall point estimate for the effect. This method is simple, but it does have some limitations. Next slide, please. For example, if we have rare events with small or zero counts at a particular data site, then the likelihood function we'll need for getting a point estimate would be monotonic, meaning we cannot get a maximum likelihood estimate from this. So the traditional method will simply throw away this entire data site, losing us a lot of information. With that, there has been emerging alternative frameworks, next slide please, that can address such information loss issues. So instead of simply combining summary statistics from different data sites, we now can actually directly combine the likelihood functions. Now here, a likelihood function can be thought of as a profile containing the full data evidence needed for inferences. In such a new framework, we can use Bayesian or numerical methods to combine all those different shapes of likelihood functions, giving us an overall likelihood profile that we can use for getting a point estimate and also uncertainty quantification. Now, this new and flexible framework, next slide, please, can also help us address challenges, more challenges at hand on top of the small or zero counts issue. For example, we can combine with empirical calibration methods to address systematic errors. So this can help us debias our effect estimates. Moreover, we can potentially incorporate latent community detection methods to account for community level confounding. So this can help us explain away some effect heterogeneity across patient groups and across data sets. So with that, let me hand it to the legendary Mark Suchard, who's a leader of the LEGEND initiative and also a leading researcher in OHDSI, to give concluding remarks.
Bon, thank you very much for passing the baton over to me. I'd like to take this opportunity to let the community know that LEGEND Type 2 Diabetes is ready to kick off. Unfortunately, Craig stole my thunder last week by announcing that the medRxiv preprint of the entire protocol for the LEGEND study is out in the wild, ready for everyone's feedback. But perhaps more importantly, it has now been officially registered with the EU PASS system. For those of you not familiar with the EU PASS registry, it's much like clinicaltrials.gov here in the US, but not just for clinical trials, for all observational studies. So that supports the OHDSI ideas of sort of open science, in that we will pre-specify and publish ahead of time exactly what types of analyses we're interested in doing at scale. In addition to finalizing the protocol, we have also completed preliminary exposure and outcome cohort diagnostics across a number of different data sources, including 3 different large US claims data sources, 2 different very large US EHR data sources, including in the VA and Optum EHR, 2 different US academic EHR systems, and internationally the EHR system in Singapore. So the formal start date for this study, now that we have these diagnostics in hand and we're looking for participants, is November 1st. To participate in LEGEND Type 2 Diabetes, you'll have to use the LEGEND Type 2 Diabetes study package, which is being distributed as an OHDSI Network R study package from GitHub. Over here on the left, I have a clip of the FACE page. At the bottom of the FACE page, there's an extensive README document that gives you both the requirements and the first steps that you'll need to generate cohorts, characterize those cohorts, and begin with the analysis itself. In order to participate, as a data partner, you'll need data that is ETL'd into OMOP CDM version 5, and our executables run against R4.05. Within the study package itself, we're using the REMV environment to make sure that all dependencies are up to date and available upon installation. And Jose Posada has been very nice to provide a test Docker file for our data partners who can use containerization. So if you are interested in participating, cohort characterization is ready for execution across our network. So please consider contributing as a data partner. No work is ever done in a vacuum, and unfortunately, almost no work gets done by me these days. So I'd like to give a huge shout out to the large team of participants in Legend Hypertension and Legend Diabetes, and also to let the larger community know that this is an open initiative, and if you're interested in participating in the scientific development and in the clinical characterization and studies that we're moving forward to with Legend Diabetes and the underlying statistical work, to please consider joining us. We meet on the 2nd and 4th, and my favorite Thursday, occasionally the 5th Thursday of every month at 12 p.m. Eastern Time on Teams. I've provided a couple of links to the published study protocol and the study package. If you're interested in participating in the study or joining the work or joining the initiative, please contact me either by Teams or more preferably from via email. And with that, I'd like to stop screen sharing and open this up to a discussion and questions from the community.
Great, thank you, Mark, and thank you, everybody. That was a really wonderful presentation. We have plenty of time for questions, so please do raise your hand. We will start with Andrew Williams.
For years, my mind is blown every time the Legend initiative is described and its achievements, and it seems like a crowning glory of the OHDSI community, and I'm just, grateful to everyone for the work they've been doing. I'm curious about how the complexities of second-line treatment are being handled, and I confess to not having read the protocol, even though it's out there on RX, but it seems more difficult, the kinds of outcomes people might have already experienced, all the kinds of complexities from failure for prior treatment, observed and unobserved, and so on. So I imagine that's added a significant additional set of parameters that Legend is trying to accommodate. If there's any way to gloss what's been done in that respect, I'd be eager to find out more about that.
No, that's an excellent question, Andrew, and it is certainly a more difficult topic than first-line treatment for hypertension. We have a large number of different exposure cohorts to handle different situations. Perhaps I'll turn the floor over to Rohan to address the different ways that we've characterized what means what second line might mean.
No, thanks, Mark. I think the biggest point would be that currently there is equivocal evidence, choice at a clinical level. Our second-line escalation approaches are still based on clinical gestalt and actual data-centered investigations haven't actually found a specific clinical indication determining the choice of a second-line agent. So there seems to be an equipoise of sorts in choosing these 4 classes of drugs, with sulfonylurea is kind of predominating. So, and our suggestion was, because metformin seems to be a static first line, all these 4 drugs would be considered second line. And we are focusing our current analytic approach in defining individuals who have at least been on a month of metformin and then have not had prior insulin exposure, which ensures that we are not taking individuals at a more advanced stage by only focusing on these oral agents. But then have specifically focused on if they have intercurrent hospitalization, exposures during those, versus at least some long-term use. So we won't consider any of these drug agents used sparingly in a short-term setting, but they have to be actually initiated and people have to stay on it at least for a month before we consider them actual second-line therapies. I hope I answered the question. It was a little roundabout.
No, that was very clear. Thank you.
Jacob. You're on mute if you're.
Can you hear me now? Am I
Yes,
coming through? Excellent, thank you. So very quick question, which was, and I'm terribly sorry, I might pronounce the name wrong. It was the speaker YUAN. I can't pronounce the name. I don't want to screw it up. I'm sorry. When we were discussing like the population size of you guys' study, as I'm still very new to the OHDSI community and learning a lot more, this is quite frankly like the largest study I've actually ever heard of in the OHDSI community. I think it's just so incredibly amazing. To quantify, like, I think you mentioned the number of 118 million patients. I had to look up, and it's about like the combined population of Germany and Australia, and I was just blown away by that. And from my side, what I was just so curious about is what sort of hurdles, or what was the logistics of actually getting to that point of being able to, weave together. You mentioned towards the end of your talk all the different data sources and data sets. How are you able to effectively kind of weave that together? Was that just by merit of the OMOP CDM that was being used, or was there a lot of logistical hurdles that you had to work through to be able to run your study?
Thank you for the question. Actually, the treatment escalation for hypertension study is not the largest one. Actually, the LEGEND hypertension one, if you just look at the database itself, the combined number of participants is even larger. I think you raised a good point about how to use this hypertension or LEGEND hypertension principle to mobilize new collaboration. I think the methods paper by Matai Shomi and Mark, they lay out a very nice framework of OHDSI, and then we are just applying that framework to this new study. All the data sources are mapped to OMAP common data model. That makes the execution of the code easier. And also thanks to the OHDSI two-stack, including ALICE to define the cohort definition and different two stacks to look at cohort diagnostic, etc. So it makes our life much easier. So once we create one of the institution has to be a lead institution for that, then we create a code, we define the definition in ALICE, then we can share this code to the other data partners. They can just apply this code and using the OHDSI two stacks to complete the same analysis within their framework. The major obstacle we found out is the data quality issue. So even all the data partners are mapped to the common data model. Some of the variables may be missing a lot in their database, and some of them may not have been installed ALICE on their server. So it actually a lot of time need to spend onto this logistical issue. To solve that, we actually have constant meeting, like bi-weekly meeting or weekly meeting with the data partner to solve any obstacle in running the code using the OHDSI two stack. So I think to answer your question, like leveraging the two stack, the principle of OHDSI and LEGEND hypertension initiative, and also with persistent team meeting regularly would be important to stimulate new collaboration within the community.
Awesome, thank you so much for your answer, and I certainly second Andrew's opinion. This is definitely a project everyone should aspire to in the OHDSI community. So thank you so much for your time.
Great, thank you, Jacob. It's always great to hear questions from newer members of the community. It's sometimes you think it's a basic question that maybe everybody knows, and the truth is that there are probably a lot of other people who are new who don't know some of those questions that may seem basic. So thank you for asking it, Jacob. All right, I saw. Let's go to Andrew and then Claire.
Yeah, Yuan, you anticipated my second question, which was about data quality work that potential data contributors might want to do prior to running the characterization package. And I was wondering if there's any guidance on, I mean, should we just go and get some of those JSON objects and start checking, you know, the data quality dashboard to see if there's concept level problems for those things, or a general strategy, maybe coming out of the meetings you've all been having, that so people can maybe skip some of the iterations of sending in characterizations and reflecting on them, so we can speed up our contribution.
Yeah, thank you for the question. I think we mostly start with creating simple characterization tables, looking at missingness across the different variables. Also, basically follow the cohort diagnostic pipeline of the OHDSI tool stack. So say we define the cohort, and then if you create an iteration map, it easily shows you like which step you reduce the cohort most. And then looking into it, what might be the reason for that? Is there any missing in the variable leading to that? And after we finalize the study cohort, we look at the characteristic of the population, and that creating the table, sort of table one in most of this table, looking at characteristic of the study population. We will also see if any suspicious number or any missingness in this table and variable. And in terms of the hypertension medication, one lesson I learned is the drug may be coded differently in different countries, especially in China. Some of them, they use like say traditional Chinese medicine may not be coded according to the schema of Western medication. So when we look at the treatment utilization, we found that, oh wow, it's so low. Some of these commonly used drugs were so low in other country that actually promised to look more detail into the reason for that.
Can I say, if just to feed back to make sure I have a clear sense of what to do, should we take the characterization package, run it at our site, and then look to see if it looks okay to us, and try and solve any related issues before we send it to you? Because I'm just trying to save some of the back and forth that might happen, and I'm not sure what the clear guidance on how to do that is. Or is there no getting around it? Maybe that's an option. I don't know.
At the moment, there's no good getting around it.
Okay. All right.
I mean, the first step in this study package is effectively the cohort diagnostics, which data partners and the LEGEND team will need to work together to identify difficulties in a specific data source. One thing to keep in mind is most of these drugs are relatively common and have been on the market for a fair amount of time. So we have an idea of what incidence should be in different data sources. That gives us an upper hand on validating diagnostics.
But I also wouldn't frame it as a negative. I think one of the things we've learned quite a lot is the value of bringing characterizations together across the network is you can make comparisons and learn across the network. It's really hard to decide if your data is fit for purpose in isolation of knowing how it stacks up with everything else.
Yeah.
Claire?
Yeah, so my question was actually going to be similar to Andrew's, just about the data quality procedures you went through. But I think to a potential solution, if you think your data partners and people who participated in the study would be amenable, I'd love to talk about how we can incorporate your learnings maybe back into some of our standard data quality procedures that we currently use at the network level, because I think that's really where we're trying to go, is get to more of these kind of in-depth understandings of your data as well, and see how we can apply that back to others in the network to just get better and better at identifying these things before they come up in a study.
It's a wonderful opportunity, Claire, that we hadn't considered, and we'd certainly like to engage individuals involved with the data quality dashboard in this type of feedback loop. I think we're at the stage where getting that feedback from the participants in Legend Hypertension, both the first line and escalation. There's probably some very useful information that we can share both ways.
Absolutely. I'll reach out to both of you and get that set up. So thank you.
Phil.
Yeah, hi. Just as a representative of a potential data partner, my question is whether this study in an AHR setting would be limited only to GPs or to secondary health, tertiary healthcare inpatients, et cetera. So like who would qualify?
So that depends on the healthcare system. In the U.S., most first prescriptions for treatment of diabetes is handled on the outpatient setting, and many of our outcomes are focused on outpatient settings. But some of the more critical cardiovascular outcomes are specifically hospitalizations and events that happen in the hospital or in emergency departments. So, the best use is data sources which capture both, but we can certainly work through the limitations of data sources which have a slice of outpatient or a slice of just inpatient as well. That adds, kind of the necessary perspective that we need to learn about how these issues work across varying healthcare systems and different data, and different data capture procedures.
Great, thanks.
Any other questions? Patrick?
So I'm a question for everybody, but I'm going to maybe just connect a couple points together. Ray presented the work from Legend Hypertension, where you saw that we had to basically run millions of hypotheses to gain what now is a relatively small number of clinical insights, but those insights are like extremely important. They're impacting the most prevalent drug being used for the disease, but it's doing the millions of experiments that actually built us the confidence in the evidence that we had to believe in those like critical findings. So I'm curious for the Legend type 2 diabetes group, Rowan, as you presented, it's going to be another very, very large scale analysis. We're going to have to do a very large number of comparisons with a very large number of outcomes and clinical contexts. But does anyone have any speculations or hypotheses of what the clinical insights might be that we're really going to be the evidence gaps we're going to fill? What are the critical questions that clinicians out there right now are facing and diabetic patients are needing good answers to that we think we might be supporting with this new study?
I think that's an excellent question. The biggest challenge I think we all recognize is that we have so many drugs available. Currently, there is no mechanism to optimize care pathways for the patients with diabetes. We have these broad generalizations that treat patients with elevated cardiovascular risk with some of the more recent therapies, but then all patients with diabetes have elevated cardiovascular risk, so that becomes a little more challenging to sort of go after. And I feel what we derive from this mostly is the fact that some of the older generation drugs that are used widely, used in a majority of patients with diabetes, if patients receiving more than 2 therapies, 80% of them are receiving sulfonylureas. And we have no evidence that those therapies are actually have cardiovascular effectiveness at all. So one of these things we'll recognize is if we find head-to-head that they have some sort of cardiovascular effectiveness, then gives us more peace that they are being treated, patients are being treated effectively, even with these older, cheaper drugs. Or if we find that there is actually a substantial difference in cardiovascular outcomes with these novel drugs, then there may be a need to sort of focus our policy away from just treating glucose to treating with these more novel drugs. And those randomized trials are not insufficient in informing this choice at this stage.
I would have thought the emphasis on subpopulations would really add to what's known about the effectiveness not only between drugs but in particular groups of patients, and that is leveraging one of the great strengths of large data sets in different populations, is to have sufficient power to kind of get at that question in greater depth than you're ever going to in a trial. Is that how you all have seen this? I mean, it was mentioned sort of what works for whom earlier on, and I again haven't looked at the cohort definitions, but I'm assuming that's one of the items of interest, whether it's demographic issues or comorbidities that are being used to define, the subpopulations.
Yeah, focusing on key subpopulation, especially around cardiovascular risk, is one of the key things we discuss, and as you mentioned, some key demographic subgroups.
Jamie, I saw your hand up. I know people are going to have to jump off, but if you want to ask, if people want to stay on, I did want to say we'll get the slides and all the links that Mark had on the community calls page. Jamie, go ahead if you still have the question. You're muted. There we go.
As you know, as many of you know, getting lots of different stakeholder buy-in for these studies before the results are reported is important, and getting everybody to agree that if these particular statistical and validity diagnostics all pass in advance and everybody agrees, then when the findings come out, it makes it harder for people to like post hoc and say, oh, I don't believe it, I don't trust it, because everyone involved. So like, other than this team of people that just presented this study, what other stakeholder eyes are on this and engaged in it? I'm wondering, for example, are there any like regulatory representatives that are thinking about this study and what the findings might be when they are eventually reported? I just want to know what the different stakeholder groups are and if there's alignment among everybody in advance, so that when the chips do, fall as they may, people will be in agreement, or whether they'll be like post hoc arguing about whether it's real or not.
Mark, it's an excellent question and a suggestion, Jamie. And one approach that we have that differentiates LEGEND diabetes from LEGEND hypertension is from the very beginning design stages, we've engaged the American College of Cardiology and the American Diabetes Association, specifically their scientific research arms, to elicit sort of feedback and support for this work. But your question is certainly, or your comment is certainly more pointed than just the professional societies. It's moving further into regulatory agencies, patient groups, and directions that we as a community and and the LEGEND initiative specifically need to take an active role in doing that engagement as early and as effectively as possible.
Great. Anything else? Okay, thank you again to the team for both this presentation and leading this amazing work. We will have the recording posted hopefully by the end of the afternoon, as well as the slides, the links mentioned by Mark, and everything else that you need on the community calls page. Thank you again, and everybody have a great day, a great week, and we'll see you next week.